Yes. Please be seated. Members of the jury, welcome back. Thank you for your patience. During trial, it is sometimes necessary to permit a witness to testify out of the regular order. And in this case, the court is allowing a defense witness to testify during the state's case in chief due to scheduling conflicts. The order of witnesses should not affect your evaluation of the testimony given. Mr. Kading, call your first witness, please.
Thank you, Your Honor. This time I call Dr. Jennifer Stankis.
Dr. Stankis, come forward, please. Do you solemnly swear or affirm that the testimony you're about to give will be true and correct?
I do.
Please be seated. Mr. Kading may inquire when you're ready.
Thank you. Good afternoon, Dr. Stankis.
Good afternoon.
Would you please state your full name, spell your last name for the record, please?
Sure. Jennifer Stankis, Stankus.
And Dr. Stankis, could you tell us what your education history is?
Sure. I'm an emergency physician. I went to medical school at the University of Washington. Before that, I went to law school at the University of Denver. And before that, I went to undergraduate at the University of Colorado at Boulder.
And what kind of work do you do?
I'm an emergency physician. I practice at Madigan Army Medical Center as clinical faculty in the emergency department.
Okay, and what else do you do for work?
So at this point, over the last few years, I've been about half-time clinical medically, and then the other half of my time is split between doing some expert work like this and other work that's not related to medicine.
Okay, and are you a member of any professional associations?
I am. I'm a fellow of the American College of Emergency Physicians and a former chairperson of the Emergency Medicine Foundation and a diplomat of the American Board of Emergency Medicine.
Okay, and Dr. Stankis, have you ever qualified to be a expert witness before?
Yes.
Okay, and what field do you expert witness in?
So I'm asked to opine on medical questions, and that can be in civil cases or like this in criminal cases. So it's been a pretty broad range of cases.
Okay. And you indicated you were an expert witness, so are you paid to be here?
I am.
Okay. And does the fact that you're being paid have any influence on your testimony?
No.
And is the amount you're being paid a customary amount?
Yes.
Okay. So we are here on the case of State versus Ali and Ali. Have you had an opportunity to review the medical records in this case?
I have.
And have you reviewed anything else?
Yes.
What else did you review?
I reviewed the police reports and also the videos.
Okay. And you saw the bus video and also the handheld phone videos?
I did.
Okay. And when you reviewed those records and that video, did the diagnosis and things that you found in the medical reports, did that seem consistent with what you viewed and read?
It did.
Okay. And one of the things that was an issue, that's going to be an issue in this case, is something called pneumomediastinum. Could you please tell us what that is?
Sure. Pneumo just means air. Mediastinum is the central cavity in the chest. It's the area, basically, media is middle, and stinum, you can think of your sternum, so it's the cavity there. Pneumomediastinum means that there's air in that cavity, and there shouldn't be air in that cavity. There should be air in your trachea and in your lungs and in your esophagus sometimes. But it means that there's air inside that cavity, which is unusual.
Okay. And so can you tell us how typically does that air get there?
So it's not a highly common condition, but it does happen.
Okay. And are there, what are some of the different ways it can happen?
So the worst way it can happen is if you are shot or stabbed, or some sort of penetration into the chest cavity that actually punctures, punctures your lung, punctures the chest wall, punctures your trachea or your esophagus. That would be a very bad day. Other causes, believe it or not, it can happen with a sneezing fit or vomiting or weightlifting or bearing down. And the reason is that think of your lungs as like a big balloon. You take in the air, it goes into your lungs, and it travels out to the small little air sacs at the end called alveoli. And if you put too much pressure into that, like anything, you can basically pop it. So you can have a situation where you bear down, or you're holding your breath, and like say someone jumps on top of you, or a dog or something like that can actually pop that alveoli. Another way that can happen is if any of you are scuba divers, you hold your breath, something bad happens, you freak out, you pop to the surface and you forget to exhale. Well, all those gases are going to expand and create more pressure. So it's a pressure issue. And then the other way is you can sometimes tear the esophagus, for example. And the way that can happen is with violent vomiting or some sort of penetrating trauma. We call that Boerhaave syndrome.
Okay. All right. So was that B-O-R, Boerhaave?
You're asking me to spell something that's not fair. I think it's B-O-E-R. I'd have to Google it.
Okay. And when the air in your lungs is trapped and the pressure is applied to it, what is that? What is that called? Is that the Macklin effect?
Yes, it commonly occurs, most commonly I would say, and that would be that effect where you're bearing down like a Valsalva. You're increasing the intracranial or the interthoracic pressure too much.
Okay. Now, in terms of generalities, is pneumomediastinum, is that something that's common in strangulation cases?
No.
And have you ever seen it in a strangulation case?
I've seen it. So I've reviewed many strangulation cases, and I have seen it in one case where I don't think that it occurred from that, but rather from being dragged from behind and struggling on the ground.
Okay. And obviously it could be common in a stabbing offense or something like that, right?
Fortunately, I wouldn't say it's common, but it does occur.
Okay. Now, the different ways that it can happen, are some of them considered more serious in terms of diagnosis than others? I mean, in terms of what you're going to do to treat them?
What I would say is that it's not so much the mechanism, but rather the effect. So there can be a very small air leak that is a one-time air leak that doesn't persist, and it goes away on its own. And that could happen from any number of things. Let's say you have a very small puncture, it heals over, and you just have a one-time air leak versus the Macklin effect where you're sneezing or coughing and you have a small little air leak. What matters is if you have a persistent or a large air leak that can create pressure inside the chest. It can actually cause a pneumothorax, if you've ever heard of that, where there's too much air in the chest and it starts to collapse a lung. You can have the air in the mediastinum that's actually putting pressure on the heart. The heart's just a big pump, so if you are creating a lot of outside pressure on it, it won't pump as well. It won't be able to do its job. And then the other way that things can go sideways is if you have a tear, especially in your esophagus, what that can do is allow the stomach contents into the or the mediastinum, not pneumo, but the mediastinum, and those contents can create a bad infection. You can become septic, and that can kill you as well. So it's not so much a matter of what the mechanism is, but what the effect is.
Okay. And how do you recognize a pneumomediastinum?
So most typically, we'll see it on a chest X-ray. So in a lot of cases, someone will come in with chest pain, or they'll come in as a trauma, and we get an immediate look to make sure that there's nothing dangerous going on. And we can see air very well on X-rays where it's not where it's supposed to be.
Okay. And so once you see that, is it pretty easy to diagnose what it is?
Yes.
Okay. And can you tell me, how do you typically treat it?
So it depends on what it is. So sometimes it's very serious. Say a gunshot wound, they'll have to go in and resect part of the lung or clamp it to stop that air leak, or put in a chest tube. Sometimes a surgeon will have to go in and repair the esophagus. A lot of times we just watch the patient. So about 80 to 90% of the time, the condition is not anything that we need to do anything about, and we'd consider it to be benign, meaning harmless. It's there, but we need to watch it and make sure it doesn't persist or get worse.
Okay. And is there any particular time limit on how long that may take?
Well, typically, if we saw a small amount of air on a chest X-ray, for example, but the patient's vital signs were stable, they weren't having any trouble breathing, everything else looked okay, we would typically watch them for 24 hours and retest and make sure that the condition isn't getting worse and that it's getting better.
Okay. And in your reading of the records in this case, did you note when the condition was first noted?
Yes, it would have been on arrival to the emergency department.
Okay. And did you then also note in the same records when it was determined that it was no longer an issue?
Yes.
And when was that?
The following day.
Okay. So do you recall, was it less than 24 hours later that the condition was no longer noted?
I believe it was.
Okay. Now, upon reviewing the medical records in this case and the videos in this case, is it possible for you to tell with any degree of certainty how the condition arose in this case?
No.
And why not?
Again, there are multiple ways that it can happen. Certainly it could be from any type of struggle where someone is in a fight or a struggle, like, for example, the first instance where there's a tug of war over Fatima and she goes down to the ground. Or the next instance might be where there's, I call it a dog pile, but there's a group of people who all fall on top of her. It could have happened there. There's an instance where they're on the ground and there's contact with her neck. It could have happened there. There's a struggle afterwards that I can't see in any of the videos. It could have happened there. I don't know.
Okay. And so once the person comes into the hospital and they are found to have this condition, is there typical conditions placed upon them when they're being observed?
Yes, so what we're concerned about, obviously, is that this condition's going to get worse. The patient may need to go to surgery. They may need to be heavily sedated so that a camera can be placed down their trachea or the esophagus, whichever one they're worried about. And in those cases, we don't want the patient to eat or drink anything because they are put at a great risk for aspiration during that procedure. So just like if I'm worried about someone with appendicitis, they come in with right lower abdominal pain, I'm going to have them not eat or drink anything until we know that it's not that and that they're not going to surgery. So we'll keep the person what we call NPO, or nothing by mouth, until we have a better idea of what the clinical picture is and if they need any further intervention.
Okay.
And then obviously we watch them. They're on a monitor. We're making sure that they're not going into any respiratory distress or cardiac distress or anything like that.
All right, and in this particular case, when you reviewed the medical records, did you see any sort of a specific treatment that was undertaken in this case?
I believe, obviously, observation, imaging in terms of x-rays, and then I believe an antibiotic was given and the patient was kept NPO, as we call it, or nothing by mouth.
Okay, and did you see any indication that there were any scopes done or anything else?
No.
And is that typical in a case like this?
I would say it is. With a very small amount of air that resolves, there's no reason to put that patient at risk because there's not an obvious ongoing air leak.
Okay. Is there typically any difference in a case of pneumomediastinum where a younger person is involved versus a full-grown adult?
The only thing that I would say is that younger patients, especially very young patients, have smaller airways, and so if there is some sort of compressive element, like an ongoing air leak, they can decompensate faster than adults, but the mechanism overall is the same. So they're treated the same way.
Okay. And can you tell me what tension mediastinum?
Yeah, so tension mediastinum, again, is pressure or tension on the contents of the mediastinum. And in that case, we're talking about compressive pressure on the heart. So if you can imagine your heart wants to beat in its usual fashion, if you're putting tension on it, just like if you're putting fluid around the sac in the heart's not able to beat as well as it would. And in fact, you can end up going into shock from that.
Okay. And if you have this tension mediastinum, then you have a more of a continual flow of air in, causing the pressure to build up? Is that what you're saying? Okay.
Correct.
And you had mentioned tears of the esophagus. Obviously, that's something that sounds pretty serious. What does that cause?
Again, so that can cause stomach contents to leak into the mediastinum. And again, that's really dangerous because of the risk of infection.
And again, no evidence of that in this case that you
No.
saw? Okay. What is a mucosal tear?
So the mucosa is like the lining of your mouth. Or the lining of your trachea. It's just a tear in that, in that material.
Okay. And was there one noted in this case?
It was suspected but not confirmed.
Okay. And what does that mean to you?
So you can't tell if someone has a mucosal tear in their esophagus or in their trachea by CT scan. You just can't see that level of detail. You need to go in with a scope and actually visually inspect it to see if there's a tear there, and that wasn't done in this case.
Okay. And is that generally, do you think, because this case resolved on its own?
Yes.
Okay. And what about mediastinitis? What is that?
So that would be inflammation around the mediastinum, as you would see with an esophageal tear, for example.
Okay. And you said one of the big issues that could be dangerous in certain cases of pneumomediastitis is infections?
It can be.
Okay. And were there any infections noted in the medical records in this case?
No.
Okay. So you said 80 to 90% of these cases typically resolve on their own. Does that just mean, what does that mean in terms of resolve on their own?
It means that we see some air where it's not supposed to be, and that it doesn't progress into a more dangerous condition. and that no intervention is needed, and so that's it. The patient gets better, and we don't need to do anything.
Okay. And so in your case, how would you classify the condition pneumomediastinum as it applies to Fatima?
I would say it was a mild presentation of it that resolved completely by the next day.
Okay. And given what you know, was this condition going to ever cause her death or kill her?
No.
Okay. And when something like this happens and it resolves, does it leave any permanent damage?
No.
And does it cause any permanent injury in any way?
No.
All right. I think that those are the questions that I have for you. Thank you.
Thank you.
Mr. Leary, cross-examination?
Just a couple questions, Your Honor. Really just about to. Good afternoon. Thank
Good
you.
afternoon.
You talked about the risk of aspiration in surgery, and that is when food doesn't stay in the stomach or saliva and goes into the lungs. Is that
Yes.
accurate?
Yes.
And so what's the consequence of food or saliva or something going into someone's lungs?
So it can cause respiratory failure at the worst. It can cause infection and scarring of the lung.
Okay. Pneumonia?
Yes.
Okay. And so when you said nothing by mouth, if somebody has to go into surgery and they have eaten within 24 hours, it increases the risk of aspiration. Is that correct?
Yes.
And so the reason to not have somebody eat during this 24-hour period is if something goes wrong and they have to go into surgery, you don't want to increase the risk of aspiration. Is that fair?
Yes.
Okay. So if this had happened on a backpacking trip and this person was a 3-4 day hike out, okay, in this scenario, no helicopter rescue, and she didn't get medical treatment, would the outcome have been different?
In this case, no.
How come?
So there was obviously a small air leak, and we know that because of the chest x-ray. If this had happened out in the backcountry, there wouldn't have been an x-ray, and probably no one would have known that it was even there. There was no demise of the patient in terms of a change in vital signs or difficulty breathing or anything along those lines. If they hadn't taken the x-ray, they would never have even known that it was there.
And so if I was backpacking and this had happened, and I'm talking to this person, would this person have known something's going on with my chest? I feel like I have air in my chest. What does the patient understand in general?
So oftentimes they'll have some pain. They may have some chest pain or some neck pain where the air is dissected or something like that. But someone who has a persistent air leak where the air keeps filling up and compressing the lungs, they become increasingly more uncomfortable, may have increasing shortness of breath or chest pain or racing heart as the heart's trying to compensate because it can't beat well, any number of things.
And in this situation, were any of those symptoms about persistent air leak, pressure on the heart, collapsing lung present from what you saw?
No.
So this is a situation where she comes into the emergency department, there's a whole array of tests done, fair? Or
Yes.
a chest x-ray?
Yes.
And what you're saying is that the chest x-ray would have been what picked up this air?
That would be the first way to pick up the error, and then a lot of times we'll do a CAT scan
Okay.
after that, and then watch the patient.
Okay. So really, this was testing that identified the issue and then was simply monitored for 24 hours.
Correct,
And there was no intervention needed.
correct.
Okay. I appreciate your time. Thank you.
Thank you. Ms. Stone, cross-examination.
Thank you, Your Honor. Good afternoon, Dr. Stankis.
Good afternoon.
It's good to see you.
Nice to see you too.
Dr. Stankis, I have some questions.
I thought you might.
Right, yep. Dr. Stankis, you talked about preparing for this case by looking at medical records. Do you recall that?
Yes,
Okay. And you also indicated that you looked at, I think, video. Did you say photographs as well?
I did, yes.
And for those photographs, were those, what photographs were those?
Oh boy, they were contained within the medical record.
Okay, and so were those photos of Fatima?
Yes,
Okay. And do you recall what those were photographs of?
primarily of her head and neck, but also just a full body video, or not video, rather a photograph.
Okay. And do you recall when you were looking at those photographs, did those photographs of her injury play into your, play is not the right word, but factor into your opinion or diagnosis or evaluation in any way?
I mean, I certainly considered them, yes.
Okay, and how did you consider them? What does that mean when you say that, ma'am?
So there was obvious contact with the neck, the head and neck. There were some abrasions on her shoulders and her neck with some bruising.
Okay, and when you were going through and trying to prepare kind of your opinion for today, did you look at any research articles or anything of that nature about either strangulation or pneumomediastinum, anything like that?
No,
Okay. And you've never met or treated Fatima before, is that correct?
I have not.
Okay. And Mr. Kading asked you about just payment for testimony being here in that customary rate. What does a customary rate mean?
So expert witnesses in this state typically earn about $500 an hour.
Okay. What about if you're coming for testimony itself?
So I typically charge my clinical fee for the day, which is $2,400.
Okay. And what about if you're writing a report? Is that extra for a report, or is that included as part of that process in time, in terms of time that you would spend?
It's included, so it's just an hourly rate.
Okay. You didn't create a report here, though, correct?
I did not.
Okay. Were you asked to create a report here?
I was not.
And you talked about, I don't recall if you talked about testifying before or working just in other fields as part of your other part of your time. Do you remember that?
I do.
Okay. Have you actually testified before
I have.
in a criminal case?
I have.
Okay. On behalf of the prosecution?
Not in trial, no.
Okay. And you talked about, in terms of your experience and where you've worked, it's primarily in the ER, in the emergency medical field. Is that correct?
Yes.
Okay, so not in like pediatric medicine, anything specialty in strangulation, ENT, nothing like that.
No, we treat adults and kids, and it's a big part of our training. Maybe 30% of our patient population is pediatric.
Sure, absolutely. And so you would assume that folks that worked in the ER were trained in a broad field of folks, right? I mean, the medical degree is the medical degree.
No, I mean, emergency medicine is its own specialty, and so in order to work in the emergency department, you have to be credentialed to do that and have specialized training.
Sure. And so you would say the same would be true for like an ENT or a pediatric doctor, fair? Yes?
Fair. As we discussed, a pediatric doctor or pediatrician couldn't work in the emergency department as an emergency physician, even a pediatric emergency department, unless they were specialty trained in emergency medicine. Any emergency physician trained in emergency medicine could work in a pediatric emergency department.
And if you were in the ER and you needed something exceptional was happening, would you call a specialist in that field
Yes.
to come assist?
Yes.
Okay. Are you aware that there are, in fact, strangulation specialists and ENTs that will confer with specialists in that field?
It's not a specialty field. Different people, different specialists would tend to see it. We obviously see it because the patient comes to us first. If there is a significant injury to the neck, an ENT doctor or ear, nose, and throat doctor might take care of that.
Okay. And ER or emergency medicine is, would you agree that that is kind of a triage medicine by definition?
No.
No? Okay.
No.
So you're admitting and then you're caring and you're maintaining care for those patients once you're done seeing them in the ER?
So we diagnose and stabilize and do the initial treatment. Sometimes, for example, we'll do a scope in the emergency department. We do a lot of procedures and interventions. If the patient needs further specialty care. So as an example, we would be the one to diagnose a heart attack. And then we would call the cardiologist to take that patient to the cath lab to do any interventions that were needed, because we obviously don't do that.
Okay, so then that follow-on care would be farmed is not the right word, but farmed out to someone else for that longer-term care after the initial diagnosis and stabilization. Do I understand?
Yeah, so once we diagnose, do any procedures we need to do, life-saving procedures, stabilize the patient, then that patient may go onto the floor of the hospital or the ICU or straight to surgery or something along those lines.
Okay, and in this case, was the request to you then, or really the entirety of the request, just to evaluate the pneumomediastinum as it existed here?
Yes.
Okay. And was there any request to opine about strangulation at all, or look into that piece of the medical records and come to an opinion about that?
There was not.
Okay. And I think you talked about those three kind of manners in which pneumomediastinum could occur. You talked about the penetrating injury, is that correct?
Yes.
And Macklin's effect, and the agreed that no one knows how to spell Borhaus effect as we stand here.
Borhaus syndrome. Yeah.
Thank you. Borhaus syndrome. And if I understand your opinion of the Macklin effect, and I don't say opinion, your testimony about the Macklin effect, you're saying that that is only happens as a result of chest compression. So it's only happening when somebody, there's an external compression on the chest and the airflow has been cut off. Is that your opinion, or are we misunderstanding that?
Well, that is one way that it can happen.
Okay.
So, as we discussed before, if someone takes a deep breath, for example, it's not unlike the scuba diving in a way. If you take a deep breath or you're startled and go down and someone lands on top of you and you have a sudden compressive effect, it's like taking a balloon and squeezing it very tightly. There's a possibility it could pop. If, on the other hand, your mouth is open and you just jump on top of the person, there's not that increased pressure, you're not going to have that effect. So we talked about that compression, but then we also talked about any type of Valsalva maneuver where you're bearing down and you're activating your abdominal muscles and you're bearing down in your chest. What that does is it increases the intrathoracic pressure. And if you do that hard enough, like with violent vomiting or struggling, or sometimes we can see it in wrestling or weightlifting, something along those lines, you can have that same effect.
And so you used wrestling as an example. So when we talk about it in terms of wrestling and bearing down and breathing hard, why did you use wrestling as an example?
Just because I've seen that happen. For example, another thing that you can see sometimes is like petechiae. That's another example of how you can have increased basically backflow that causes little ruptures. In that case, it's with the vascular system, not the airway. But it's the same concept. I've seen it with people who've been arm wrestling, for example.
So when you're talking about, let's say, like petechiae or the pneumomediastinum, let's say that somebody is strangling you from behind, they have you in a armbar and you're gasping for air. Would you anticipate that that could cause a pneumomediastinum and or petechiae?
It could, yes.
Okay. Would that be consistent with the Macklin effect then that you're talking about?
It could, yes.
Okay. You talked about identifying if there is a tear in the trachea or esophagus by potentially doing a scope. Do you recall
Yes.
that? Okay. That's pretty common means for checking to see if there's a tear. Is that fair?
Yeah, and I would say that if you're talking about a mucosal tear, that's the only way to see it. You won't see that level of detail on a CAT scan.
Okay. And would you agree that if there has been trauma to someone's throat, you may be disinclined from a medical perspective to put a scope down there and add trauma to see if there's already trauma? Does that question make sense?
It does make sense, but you're not causing more trauma by putting a scope down. You're basically, so when you're talking about the trachea remains open, unlike the esophagus, with the cartilaginous rings around it. It's always open. It doesn't collapse like the esophagus can. You're just putting a small, I almost want to say like this, the caliber of this, and there's a little light and a camera on the end of it, and you're literally just going down and you're looking around to make sure that you don't see any injury, like no bubbles of air or blood or other things that would indicate an air leak. So I wouldn't say that it would cause more trauma.
Just wanted to indicate the doctor held up one of the cables, very thinner cables from the microphone system as she was trying to describe the size of the scope.
I apologize.
Well, you're fine.
And I would say it's about a 1/4 inch diameter.
Thank you. And earlier you said one of the concerns that you have when dealing with children is that I'm going to use the wrong term, so please correct me, that the throat size is smaller, right? The airway is smaller. Is that fair?
Everything's smaller. Yeah.
Right. Yeah. By definition, everything on a child is smaller. Does that give you then more concern or more, are you more cautious then as a doctor in terms of injuries that may have occurred to a child and how you're going to treat that child?
Yeah, so like I said, if for example, there's a persistent air leak in a child, it may cause decompensation more rapidly, especially around the airway, because it's a smaller airway to have to compress.
So in this case, would you, knowing that a pneumomediastinum is presented in Fatima, knowing that the injuries that she has incurred and knowing what has been described as the cause of those injuries, and specifically a prolonged strangulation, are you saying you would have scoped Fatima to see what was happening in her throat, or do you agree that the scope was not appropriate?
Well, the reason it wasn't appropriate was because it was such a small amount of air, and because there was no respiratory distress, her vital signs were normal. If you were truly concerned about a persistent air leak due to trauma, or you were concerned that there was a lot of swelling around the airway and that the airway would be closed, you'd actually probably prophylactically intubate her. So if you were worried that there was that much trauma to the airway, you might even intubate.
You might, but not necessarily.
If you are worried about airway and significant amount of soft tissue swelling, especially over that next day, but not without any respiratory distress, not without any difficulty breathing or swallowing or voice changes or evidence of, for example, fractures in the cartilage of the neck, I don't think it was indicated in this case.
And that would be assuming you know what the source of the leak is, though, also, correct?
Not necessarily.
Okay, so tell me about that.
You could have potentially a small mucosal tear that creates a one-time brief passage of air into the mediastinum and seals itself over. and you don't have a persistent leak. You could also have one of the alveoli rupture, like we talked about in the Macklin effect, and you have a transient passage of air, it seals itself up, and that's it. There's no additional leakage.
But you don't know what that source is without looking. Is that fair?
You can't know.
Okay. And the standard of care, if you're worried about someone with a pneumomediastinum, is that you call an ENT and or keep them for observation. That's correct? I understood that from your
Yes.
testimony. Okay.
Yes.
And is that because that condition can go poorly? It could go great, but it could also go very poorly. Fair?
Absolutely.
Okay. And I think, as you said earlier, you're not involved in that aftercare. You know what the care is supposed to be, but you're not actually involved in that. Fair?
Fair.
Okay. And you're not just sending a patient with pneumomediastinum home and saying, call us if something goes south, right?
I wouldn't do that.
Okay. Would that be the same with strangulation patients then? If somebody came in and said, complained of strangulation, said it described this incident that occurred to you, and you saw a pneumomediastinum, you also wouldn't be sending that patient home and saying,
Correct.
just call us.
Correct. So the things that would keep that patient in the hospital would be significant airway restriction of the airway, or significant swelling around the structures of the airway causing constriction on the airway, any type of vascular injury, any fractures in the neck, or pneumomediastinum.
Okay. And so you said you agreed that pneumomediastinum can occur after strangulation, and particularly that manual strangulation creates that increased air pressure in the chest cavity during the incident itself. You would agree with that?
It can.
Okay. And when that air then leaves the chest cavity and air moves, right? Generally speaking, it's not stagnant?
Yes, it moves.
Okay. And if it then dissects the neck and the chest, can that cause a subcutaneous emphysema?
Yes, in fact, sometimes that's all we see. So one of the things that we do in trauma patients is we always just feel the skin, and we call it crepitus. And so sometimes you can definitely feel that the air in all of the tissues.
Can you explain to the jury what subcutaneous emphysema is?
It's just air within the skin tissues and the fat. And so it's almost like we call it like Rice Krispies. So if it's there, a lot of times you can feel it. It feels very odd. It's not supposed to be there.
It's another place the air is not supposed to be, is under the skin?
Yes.
Okay. And I think I understood your testimony with Mr. Kading, but you indicated that some of the complications that can arise from pneumomediastinum is the mediastinitis,
Yes.
okay, and tension pneumomediastinum.
Yes.
Did you talk about pneumopericardium?
No, but we kind of discussed that same mechanism.
You kind of talked about the pneumothorax, is that right?
Pneumothorax, but also compressive elements on the heart.
So if you're talking about pneumopericardium, can you tell the jury what that is?
So it could be air within the pericardial sac. So you have the heart, and then you have the sac that surrounds the heart. And sometimes you can have blood that's going into there, bleeding into that sac. You could, with penetrating trauma, have air. Or you could just have air within the mediastinum itself that is building up and just having a compressive force on all of it, on the pericardium and the cardiac tissue itself.
And each of those complications that arise from the pneumomediastinum could all potentially be life-threatening if things don't go well. Is that fair to say?
Yeah, if you have continued pressure on all of those structures, that can cause collapse of lungs and cardiovascular collapse or shock.
Okay, thank you. And you talked about something being benign. I think you used the word benign with Mr. Kading, that in this case, the pneumomediastinum ended up being benign. You don't know that something is going to be benign at the outset, right? Meaning, maybe I phrase this a different way. You could have a concussion, you could have a brain bleed, you could have swelling of the brain. All of those things could end up, or a tumor, all of those things could be benign, but that it could also not. Is that correct?
I think the examples are not any examples I would use. Like,
Okay.
You could have abdominal pain that ends up being nothing requiring surgery or any intervention. Could you have a really small brain bleed that doesn't require anything, doesn't cause any swelling? I wouldn't use the example of brain swelling. That would be
Okay.
that would be more serious under
You
any
wouldn't call that
circumstances.
benign.
No.
Okay. Would you keep, generally speaking, what else would you put in the category of benign?
Some sort of like a mole. It's not going to progress to, it's abnormal, it's a growth on the skin, but it's not going to develop into a cancer probably.
Sure. But would you agree that someone with, say, for example, a mole doesn't come into the ER and then get admitted for observation for a number of days?
No, but I would also say that we keep people for abdominal pain while we're waiting results to make sure that there's nothing serious in that. And we may not do anything about it. There may not be anything serious with that, but we still need to look.
Sure. And if Fatima had just come in with just pain in her chest and just a pneumomediastinum with nothing else occurring, is it your opinion that maybe the treatment would have been different than it is in the current case?
No, I think she would have been admitted and observed to make sure that that wasn't something more serious.
And when the pneumomediastinum resolved, so to speak, within 24 hours, she wasn't released either. Is that correct?
I don't believe so, no.
Okay. And if I understand, you said it's not uncommon, but it's not common either. Pneumomediastinum as a one of the effects of strangulation. That's not common, but also not uncommon. Is that correct?
With respect to strangulation, I've reviewed hundreds of cases, and again, I've only seen one other case.
And yeah, I think you described that case as a dragging case. Is that right?
So the person was dragged by a hoodie and then got into a wrestling match over a phone or something.
Okay, so there was pressure around that person's neck, and then they were drugged by that pressure, and then wrestling of some sort occurred as well. Is that fair?
Correct.
Okay. And in the course of your, remind me how long, I believe you said it was 10 years at some point in the ER, is that right?
Yes.
Okay. In the course of your 10 years, how many times have you seen pneumomediastinum?
You know, actually, we talked about this. I don't keep track of these records. I don't know. Maybe a dozen, like, gross pneumomediastinum. I mean, we see that subcutaneous air, so we know that there's an air leak somewhere, but you don't necessarily see pneumomediastinum on imaging. But again, it's not particularly common.
So less than a dozen times in, a dozen or less times in the last 10 years?
I don't know. I think that's probably an understatement, but I don't want to overstate either.
Sure, no, I appreciate that. And you don't have a recollection of male, female, young, old, is that fair?
That's fair.
Okay. And would you agree that strangulation itself is very serious?
Yes.
Okay. And would you agree that strangulation in a child is potentially even more concerning than an adult?
I mean, they're both concerning. But what I
Sure.
would say is, as with the pneumomediastinum, in kids, the airway is more narrow, and so it takes less to close that airway. So if you have an airway that's an inch in diameter versus a half an inch, obviously, it takes less to close that half-inch diameter airway.
So then, if I understand right, your testimony is that plainly the amount of force that it would require to significantly damage a child would be less to damage a child than it would be to use on an adult. Is that fair? I mean, in terms of close.
Adult's neck and that sort of thing is more than most kids anyway.
Well, tell me, what do you mean by that?
Just all the tissues in the neck, and obviously there are people on the jury, for example, who have more muscle and more tissue that would have to be compressed to get to the airway.
So, if I understand correctly, that a child's neck is just generally more vulnerable or more susceptible to that. Is that correct?
I'd say that's probably accurate.
And would you agree that a 17-year-old, a small 17-year-old female might fall into that category?
And she is right on the cusp of being an adult, but I don't have an opinion on that.
Let's say if she's 5'1" and she weighs 100 pounds, would somebody of that stature be more concerning in terms of what an adult is able to do to them if they're strangling them?
What I would say is that it's all concerning. It's hard to differentiate any person. A smaller person is going to be more vulnerable than a very large person.
Sure, and obviously not to minimize strangling to anyone, correct? But if you're talking about a child, you have concerns about the impact on a child that would be different, whether it results in a pneumomediastinum or one of the other complications that you've identified. Does that impact a child and their development differently potentially?
I mean, at 17, we're talking almost fully grown, but I'm not sure what you mean.
Well, at 17, a child's brain is still developing. You would agree with that. There's still another brain development curve from 22 to 26. So
Sure.
They have developed, but there's still more to come, yes?
Sure.
Okay.
Although I'm not a neurocognitive expert, but sure.
Well, would you agree that there is a brain development still coming from 22 to 26? Give it thereabouts. I mean, and car insurance companies figured it out a lot earlier than the rest of us. Fair?
And rental car companies.
Yes. Fair?
Fair.
Okay. Would you agree that if you saw indications in the emergency room of strangulation of a child, you wouldn't simply indicate that it was benign and send that child home, let alone home with their parents? Is that fair?
So typically what our practice is in the emergency department is, again, if there is evidence of strangulation, we almost always do a CAT scan of the head and neck, and we look for any vascular injuries. We look for any fractures in the neck. We look for any significant swelling of the neck. If the patient if all of those things are normal, it would be our standard to send that patient home with return precautions. If any of those things are abnormal, it would be our standard of care to admit them, at least for an observation period.
And if you have a child coming in complaining of strangulation and you're seeing that pneumomediastinum and the allegation was that the parent was the perpetrator, would you be sending that child back home with that parent?
I mean, I think the question in a certain sense is moot, because if you see pneumomediastinum on any patient, I would admit that patient for observation.
Okay. And do you agree that strangulation, whether pneumomediastinum is present or not, can result in death?
I'm sorry, ask that one more time.
Sure. Do you agree that strangulation, whether pneumomediastinum is present or not, can result in death?
They can, yes.
Okay. And you don't regularly see pneumomediastinum as a symptom of strangulation. That is the rarity versus the normal.
Yes.
Okay, thank you. I have no further questions at this time.
Mr. Kading, redirect.
Regarding pneumopericardium, was that what it was? I didn't ask you about that. Was there any indication in any of the medical records that you reviewed in this case that that was in any way an issue?
No.
Okay. And you started talking about some other things I didn't ask you about, like the subcutaneous emphysema. Is that what it was?
Yes.
Okay. And that's where the air is in a different place rather than in the mediastinum area?
So, as we discussed, air likes to move. And so if you have an air leak from the alveoli, the small little sacs in the lung, it's going to start tracking and moving because there aren't like fascial planes or something to stop it. It's going to move around the mediastinum, and with gravity it goes up. So it's going to move its way up. It can also move its way out into the tissues and eventually get resorbed into the tissues. And so you can get this air under the tissues. It's actually better that it goes there than stays in the chest and starts compressing things.
Was there any of that in this case that you saw in the records?
Not that I'm aware of.
And just to clarify then, the air that's in the mediastinum area, what happens to it?
It eventually just gets resorbed.
Okay, so you don't have to do anything to make that happen.
No, unless it's causing a compressive effect, and in that case, we may have to dart the chest with a needle and then put in a chest tube or something like that.
And that would be an indicative of a ongoing air leak into that area though, right?
Absolutely.
And that was not in this case?
Correct.
Okay. I don't think I really have any more questions. Thank you so much.
Thank you.
Thank you. Mr. Larry Recross?
Thank you, Your Honor. I just want to follow up on a couple of points. So Ms. Stone asked, you admit the patient, and she kind of gave you two options. One, it could go poorly, or two, it could go great, correct? That's
Correct.
what, I mean, that was the dichotomy that she set up, correct? Do you remember that?
Yeah, I mean, that's what we're looking for. We're looking for, is this getting worse? Is it resolving? Is it staying the same?
Right. And so to admit a patient is precautionary in some instances, correct?
Yes.
And would you agree that in this situation, it was precautionary for monitoring to see what happens next, correct?
Yes.
She wasn't admitted directly into surgery, correct?
Correct.
And that could have been an option if it appeared that, you know, her vitals were showing signs of distress, correct?
Yes.
Or other indications that this was not going well, correct?
Yes.
But at this point, it was simply in a monitoring phase.
Right.
And then within 24 hours, it turned out that further intervention wasn't necessary, correct?
Yes.
Okay. And then I think you answered this question that I'd written down, but so in terms of the presence of air in the chest cavity, best case scenarios is it resolves naturally. It dissipates through the tissue, through the body, correct?
Right.
The other alternative I think you just talked about is you insert a needle to then release that air, correct?
Yes.
And having, I think it's kind of obvious, the preferred way is to have it resolve naturally, correct?
Absolutely.
And that's what happened here.
Yes.
All right, so kind of, at this point, just because she's admitted, there wasn't a probability of death absent medical intervention, fair?
Fair.
There was no indication of permanent loss of lung function, correct?
Yes.
Or esophagus, trachea, no long-term disfigurement, correct?
Correct.
And no permanent loss or impairment of her function, correct?
Correct.
Okay. So this was an issue that was identified, it was observed, and it resolved on its own. Fair?
Fair.
Okay. Nothing further.
Ms. Stone, any further cross-examination?
Very briefly, Your Honor, thank you. Dr. Stankis, I just want to be clear. Admission is precautionary, but you don't admit most patients to the hospital that come into the ER, right? I mean, fair to say you see hundreds or thousands of patients a year in the ER.
Correct. So we call for admission, and a hospitalist or a surgeon will admit the patient.
And in this case, Fatima needed medical admission and medical whether how that condition is treated before you know the outcome either. Fair? Meaning because it went well for her doesn't mean that's how you decided whether it was a condition that needed observation or not.
Yeah, so anytime we admit someone for observation, whether it's chest pain or, in this case, pneumomediastinum or airway precautions, that condition may or may not, the thing that we are worried about may or may not happen, but we still admit them to make sure that it doesn't, or if it does, to intervene as needed.
Sure, and as you reviewed those medical reports for Fatima, when counsel, I believe Mr. Leary just asked you about, you didn't see any indication of a permanent injury, and the outcome of the pneumomediastinum wasn't a probability of death. The pneumomediastinum itself, is that correct? I mean, you said no, you agreed with him that that was not a probability of death based on the pneumomediastinum itself. You agree?
Yes.
Okay. But the pneumomediastinum was accompanied by strangulation, and strangulation itself can result in death. You agree with that?
Strangulation can result in death.
And Fatima didn't show up at the ER with a skinned knee and a bruise on her thigh. You agree with that after reviewing the medical reports?
Yes.
Thank you. I have no further questions.
Mr. Kadeen Rebrecross?
Yes, just one point of clarification, if I might. So, doctor, let's say that I have a hangnail and it gets a bad infection and it spreads up my arm and goes to my heart and kills me. Can that happen?
It can.
Okay, no further questions, thank you.
Mr. Leary, anything further? All right, anything further, Ms. Stone?
Are you admitting the person with the hangnail, doctor?
If they have evidence of that spreading infection up their arm, they may be admitted for IV antibiotics to make sure that they're responding to it.
Sure, when there's an indication that something has gone significantly different than a normal hangnail. Is that fair to say?
Correct.
Thank you.
Mr. Kadeen?
No more, thank you.
And may this witness be excused?
Yes, Your
Any objection, Mr. Larry?
No.
Ms. Stone?
No, Your Honor, thank you.
Thank you. Dr. Stankis, thank you very much. You are excused and you may step down. Members of the jury, we are going to recess at this time, and as you know, we are not in session on Friday, and so we are going to resume the presentation of evidence on Monday. Thank you very much for your time and attention. Thank you for your patience. And also, I know I say this every day, and I will say it every day that we are in this process. Please continue to follow all of my instructions. Please continue to be vigilant to ensure that no outside information comes to you in any fashion about this case. Thank you. I'll have the bailiffs come forward. Please be seated. All that energy about rescheduling, and we didn't need to, which is a good thing. All right, Ms. Stone, can you please indicate who you believe will be called on Monday starting?
only, Your Honor, that I think it's not an issue. I sent an email on Tuesday, maybe. The state, going back through either Monday night or Tuesday night, was looking at its proposed jury instructions. I know we're not there yet, but I did inform defense counsel via email that we had proposed 3504. It should have been 3508. It is a missed jury instruction, and we are going to propose and fix that. But I will let them know in advance, and so we will prepare that and provide that to the court. I know we're not at jury instructions yet.
Well, I have started to look at the jury instructions, and so do you know what number that you numbered it within the packet that is the misinstruction?
I don't, but I will find it. I know that it is, the one that was proposed is 3508, and it should have been with the 3504.
And what is that related to?
It's the to convict on assault, the to convict instruction on assault in the first degree, Your Honor.
Thank you. Mr. Kading, do you have any issues to address?
I do not, Your Honor, thank you.
Thank you. Mr. Leary?
I did have a conversation with the state in terms of how far out they have witnesses scheduled, and I think they are targeting, or at least not targeting, estimating Wednesday, just to throw that out into the ether so that we have an understanding that that is a lot faster. I'm not complaining about. So just so the court is aware of kind of where, I don't know if my client's going to testify. Obviously, I don't know if Mr. Ali's going to testify, but just so there's some understanding of kind of where we're at.
I appreciate that information. Definitely.
What I was gonna say, add to that, Your Honor, is we did have other people that we had anticipated, but they're not available till what I would say is next week, because when we were talking about it, we thought things might go much slower with the interpreters. I will say from the state's perspective, that has not impacted the speed at all, which we're super appreciative of, but that also means because of scheduling, we have a couple of days with no one, and that is not the state's intent to have no one, and I think the people that are potentially scheduled or were scheduled for next week, which would be like Principal Dean, Miss Kinley, those individuals, I think we can cover that testimony through other school officials, for example, that are here next week. So in order to keep things moving, and I don't think it impacts the state's case substantively, to just not call them, which if that's the case, then we may likely be done by Wednesday with the state's case in chief.
All right. Thank you. And thank you. That is very good information for the court. Did you have something you wanted to add, Mr. Leary?
I do intend to take a look at jury instructions this weekend, and I will make, if I have suggestions and modifications, I will provide a preliminary draft on Monday morning. It kind of depends on, I will have information for the court with respect to jury instructions Monday morning.
All right. Well, you preempted my question to you because I am looking at the instructions and I have the state's instructions. I have Mr. Kading's instructions, and I was going to ask you about your instructions. So that is helpful for my perspective as well. And so the parties understand, I'm sure every judge does instructions differently. What I intend to do and what I do in every case is that I compile the proposed instructions, and if there are identical instructions, I only include it once, but where there's a different instruction, I always include a different different because the language could be different, and or a completely different instruction. I include all of them in a draft instruction in the general way in which I would ultimately give them to the jury. And then that is what we will address to hear argument and exceptions and the like. So everyone's looking at just one packet of instructions instead of three as we go through them. And so I wanted to indicate that one. And then two, in looking at, Mr. Kading, at your instructions, you have the instructions related to if the jury were to find self-defense, find Mr. Ali not guilty, where self-defense has been asserted, the instructions then related to findings and whether or not there could be reimbursement. Those I'm going to have as a separate, they're set, I'm sure that's what you intended, but those will not be part of the general packet themselves because those would be given at a different time.
Yes, I understand,
Okay.
Your Honor, and I did have other instructions, and I didn't know if you wanted me to give you those regarding like lesser included instructions and that sort of thing. I assume the state is anticipating something like that, but if not, those I can send up as well.
So a couple of things. Certainly, I expect that the court could receive proposed jury instructions up and until the close of evidence because things change and the like. But if you know that you are going to offer certain instructions that are not part of what's currently before the court, I would not only like those, a cited copy as a bench copy, and then the uncited as the electronic copy. Because I only use uncited in the Word version that I'm going to put together, but I like the cited copy and a hard copy because that's what I'm using to compare. Does that make sense?
Yes, I think so. I typically try to just deal with cited and then just remove the cite. 'Cause that's the
Yeah,
easiest
I don't
way.
want to have to remove the cites.
I got you. All right, I will do that.
But the unsighted, you would like electronic, and you don't need a paper. unsighted.
That's correct.
Okay, all right, got you.
I honestly think that that is an old-fashioned rule, and it was put in place that you had to provide a hard copy of uncited rules when judges at some point, I never did this, used those to actually put their instructions together.
That does happen in other courts.
And the unsighted copy in a Word version, not PDF.
Yes, please. Okay, I believe that we have addressed all issues. Do the interpreters have any issues that the court needs to address?
Thank you for asking.
No, Your Honor, so far nothing.
Okay.
No, on my end as well. Thank you.
All right. Okay. We will be in recess then until